Good afternoon. Glory be to Jesus Christ.
Glory be forever.
My name is Deborah Larmer. I'm the director of the Family and Life Office, and we are really pleased today to have some expert speakers on the topic of a good death, a Catholic perspective. Dr. Brian Brownbridge is going to start this afternoon off with his presentation, and after that we will have a panel consisting of Dr. Brownbridge, as well as our own Bishop Brian, and Teresa Hebert, who's an ICU nurse. Dr. Brownbridge's expertise is in the field of anesthesiology, I always trip on that word, and critical care, and he has many, many years of experience. He is also a man of faith, and I'm sure that you'll really enjoy his presentation. So if you would join me in welcoming Dr. Brownbridge.
Thank you very much, Deb. Can you hear me okay? I can turn it up if you can't. It was working okay. So just to give you a little background, I have been involved in critical, I count my residency now for, I guess coming up this summer will be 25 years. So I have a little experience in dealing with ICU. Some of the facts about critical care. Teresa and I both work at University Hospital. I work half time there and I work the other half at St. Paul's. So we deal with issues on patients dying, unfortunately, is a real factor in our life. In fact, if you come to an ICU in Saskatoon, you have somewhere around a 20 to 30% chance that you're not going to leave hospital alive. That's the reality of coming into critical care. So if we compare that to a palliative care doctor, unfortunately, Teresa and I deal with this issue more than most physicians do. So that's not to say we know everything about it, and we grapple with it as well. But I'll bring you some of my perspectives on what I've learned over the years of dealing with it. Deb mentioned I have a captive on this. I do have two cousins that are priests, and it's not unusual for Father David, who is at the cathedral, to give me a call and say, Brian, I need you to go in and have a look at one of our parishioners. Their family are struggling with this issue. And so as I said, I've been involved in that as a third person, a third intensivist involved, to try and bring some sort of sense to care that we're delivering. So first of all, the Catholic Church has a great tradition in telling us what to believe. And I must admit, in preparation for this, I had to go back and look at our traditions and sort of bring it to sort of perspective in my opinion as well. And Bishop and I are going to sort of open up with some of the sort of 6 points in the Catholic faith that have been around for a number of years, look at modern ethics and the law, and then get cases. And then we want your opinion, what you would do, and why it would be okay and why it would not be okay to manage the patients in this case. So the first thing is, we'll make this work. There we go. Maybe I'm projecting it the wrong way. How's it going, Deb? There. So Francisco de Vitoria was a Spanish scholar and theologian, and in 1500s he actually coined many of the sort of principles that we still use today, and that was based on St. Thomas Aquinas. So going back 600 years, he coined some of the first sort of beliefs that are still used in making decisions about end-of-life care in our faith. Go ahead. So his first point was, human life is a great gift from God and a great good, but not an absolute good and not the ultimate good. And that, what we're saying is that unfortunately there's times when the good of society or the good of the overall is greater than the good of the individual. And that is one of the sort of statements that we still believe in. In this time of abundantness, we're not forced to deal with this particular issue. In times of shortage, this may be something that we have to deal with. So in times of pandemic, we do what's called triaging, to sort of give the care to patients that may need it. And in some of these sort of principles, we can get guidance that it is okay to do that. And we don't have to give care to everybody. We have to be able to choose the ones that potentially have the best reason to survive. And it is a tough call. It's really a difficult call sometimes in medicine. As I said, and can make those choices, but in the developing world, they're made every day, okay? And we're very fortunate in Canada. Next slide, Deb. Man is not the master of life, but should use all the fitting means to prolong life. If the means to prolong life are not fitting, or if they impose an excessive burden, they need not be utilized. And this is the key thing that we still believe as Catholics, both with Roman and Ukrainian Catholics, is you do not have to do everything. That's the one that I get called in many times is, you know, we have to do everything. Even if there's limited hope, we still have to continue and keep doing our best and everything like that. And what we're saying is it depends on what those burdens are. And we don't use quality of life. That's not what we use in our faith. We use burdens. And we'll get into discussion in the cases what those burdens can mean. The ultimate human good is actually friendship with God, and all humans should be ordered to ultimate end. So that's what we want to do, is become closer to God, and that's what we strive for. God doesn't desire us to be interested in a long life. He's interested in us in a good quality of life and a good life, and that can mean, you know, doing good to others and that type of thing. You can sacrifice your life, I guess is what we're saying, in a noble cause if that is in the goodness of God. We have to be careful on that because what that good cause is depends. So, but it is possible if the goal of our goodness is to be in a good life, then we can sort of sacrifice. This is the key thing, and this is where the issue of euthanasia and assisted suicide comes in. Basically, it's different to kill oneself or kill another than it is to not prolong life, okay? And that is a key sort of thing. As I was saying to my wife in preparing for this, the difference between sort of euthanasia is basically what is in your mind, okay, when you're performing the act, all right? If the act is I'm relieving suffering and I'm giving medicines to make you comfortable, and unfortunately, because of those medicines, you die, that's not bad, okay? But if my act is to shorten your life, to lessen your suffering, that is not right. Is that clear? Okay? So that's the difference. It's what is my intent when I'm offering care to you is, my intent can never be, I'm going to shorten your life to relieve your suffering. That's not my goal, okay? My goal is to treat your suffering, and if by chance your life is shortened, that's a circumstance. That's called double effect. But that's not my intent, and it's basically what is the mind of the caregiver. So if we look at basic ethics are one physicians around the world now in the developing world, and they fall into, and they're also legal courts as well. They're driven by these basic ethical principles. And one would say that these are Judeo-Christian based ethics because they're different. I've worked in the Muslim world as well. I've worked in Abu Dhabi for 3.5 years and have some experience in Islamic country. Their ethics are not the same as ours. They're different, okay? And so ethics are somewhat contextual based on your religious background. So what we feel are important in the healthcare area are autonomy, justice, beneficence, and non-maleficence. And when we talk about autonomy, that means a patient basically has the right to make decisions on their care if they're of competent nature. Now, as physicians, we may not concur, as healthcare providers, we may not concur with those decisions, but we have to accept those, okay? So you come into my office and I'm your family doctor and I say you got hypertension and I prescribe you a medication and you don't take that medication, I can't do anything about that. I can control you, but I still have to see you as a patient, okay? Even though I don't necessarily agree with the fact that you're not taking your meds, I still have to accept that that's your free decision to make. The issues of more complex decisions on end-of-life care and stuff, those become much more difficult. And this is where the issue of doctor in my life on this day, because I have too much suffering, do I have to respect your autonomy? That is your autonomy to make that decision, but do I as a physician have to honor that? And that's where it's becoming much more complex. Now, as Catholics, we don't fully accept the whole notion of autonomy. We believe in autonomy to a point, okay? Patients have a right to control their sort of decisions, but there's also an absolute we believe in, and that's the sanctity, sacred and inviolable character of the human person is an absolute. That is what we believe, is that there's something inherent that is worth preserving in human life. And that's where we struggle with autonomy versus this particular sort of doctrine that we believe in as Catholics. And I must admit, it's a controversial issue. So the areas where you'll see it is basically in assisted dying, in sort of technologies, in abortions. Those are the areas where people argue I have the right to control it. This is my sort of autonomy, that I can control these things. And as I said, in our church, we feel that there's a limitation on that autonomy. So beneficence, I should always try and do good is what I should always do. That's basically what it means as a healthcare provider. The problem is medicine has become much more complex, and even though I'm always trying to do good, go ahead there, Deb, I also don't want to do any harm. But nowadays, as I say, take on sicker and sicker patients, the risk of doing harm is potentially higher. And therefore, we have to realize that although in the days in the Hippocratic Oath and stuff like that, the thing is, I never do any harm, we realize as physicians and healthcare providers that it does do harm at times, okay? We have complications. It can make you sicker than what you started with. And that's not what we're aiming for, but we have to realize that that's the reality of what we're doing as healthcare providers. And we have to be honest with patients about this risk to them. So although the old thing is do no harm, the reality is in healthcare it is minimize harm to patients as much as possible. And that's what we all train for and try and prevent, but it does happen. Now, when you talk about, sorry, Dad, if you can go back there. When you talk about, I was just talking about it there, in a terminal patient, when the patients are coming near the end of the life, sometimes they're very difficult to deal with pain management. And one of the things that we are forced to do is escalate the doses of analgesia to deal with their pain. Now, you can argue that some people believe that's a form of euthanasia. The reality is what we are doing is trying to deal with their symptoms, and the effect it may have on reducing breathing and those type of things is what's called the double effect. We're giving it to relieve suffering. We're not giving it to end their life. It may shorten their life, although some evidence suggests that it may not as well. But no one's done an actual trial to say, if I don't give you morphine, are you going to do better or not? That would be sort of inhumane. So most people feel that in reality, if we deal with pain management, occasionally life may be shortened, but that's not the goal of the medicine. The medicine is there to relieve your suffering, is what it's for. So justice comes in. How much do we all deserve? What is reasonable? What do we expect? How much should I expect of society to pay for health care? It's maybe not an issue in Canada now, but it certainly is an issue in many parts of the world. The leading cause of bankruptcy in the United States is health insurance, okay? That goes to show you how when you don't have a socialized health care, how much an effect that has on the society. So many people go bankrupt in the States. In the developing world, it's just not available. These decisions are very easy because the health care is not there. So friends of mine work in Africa. There is no ICU, okay? If you have to be put on a breathing machine for more than 24 hours, you die in many countries in Africa, okay? That's the reality of the care we are facing. It is only when we have the excess that these issues become much more complex in our society and require even more guidance to sort of help us through. So one of the questions I ask you is, and this is a scenario that I asked the ethicist at St. Paul's when we thought H1N1 was going to be a huge pandemic. What if I have an 85-year-old patient on the ventilator, and now I have two 25-year-olds in emergency that need that, okay? What do you do? And those are tough questions. Those come into justice. They're very difficult ethical questions that we have to face. And so it's not easy to make those, okay? If you follow the justice, everyone equals the same sort of principle. But if I tell you that the 25-year-old has a 90% chance of surviving and the 85-year-old has a 10% chance, okay, well then, you know, is that ageism? What is that? So these things that we as society and Christians and Catholics have to deal with and figure out what the right answer is. And as I said, I struggle, and I've been doing this for a number of years. So here's our first case. This is an actual case. I've camouflaged it a little bit, but both of these are cases that I've dealt with. This is GS. GS is an amazing man. He's the most lovable, kind man that we all fell in love with, sort of thing. He presented when I was on at ICU. He's a 60 retired carpenter who presents to hospital with a severe pneumonia. And he's had 40-pound weight loss, and that was unplanned. He just started losing the weight over the last 6 months. And he's also noticed his energy levels have significantly been lowered over the last year. Despite appropriate medical care on the medical ward, he starts deteriorating and he requires admission to ICU for intubation and ventilatory support. And a mechanical ventilator is what most people call life support. That's what they mean when you say life support. Just so you know, I don't like the term. I talk about artificial support, mechanical support, but in the lay literature, life support means the breathing machine is what it means generally, okay? And there's different components of life support, but that's the most common one. He has a feeding tube inserted through his nose into his stomach so we can keep his nutrition up. And he proves what we call difficult to wean from life support, from the breathing machine. Can't get him off. He's just too weak. He becomes too stressed when we try and get him off. After 14 days, our usual thing is to move on. If we think the patient's going to be longer on life support, we move the breathing tube from the mouth, the tube in their airway here, down to here, and that's called a tracheostomy. And the goal of tracheostomies in ICU is to make it easier for people to come off. So that you can imagine that long tube that people are breathing through is fairly hard to breathe through. So if we shorten that up, easier to breathe is why we would do a tracheostomy. His clinical picture is a little confusing. He gets up, he sits at the side of the bed and everything like that, and he mobilizes and walks around, but we just can't get him off life support. So we, go ahead, Deb. We get a neurology consult, and he's diagnosed with amyotrophic lateral sclerosis, or Lou Gehrig's disease. And there's two peaks, there's two different types of Lou Gehrig's. There's an inherited one that runs through families, and there's a spontaneous one that around his age, around 60s or 70s. I've actually lost an aunt at 72 from Lou Gehrig's disease. So it's one of those diseases that's out there. And I think we're more aware of it because people, we make the diagnosis now, sort of thing. Anyway, he's diagnosed with that. Neurology tells us in him that he has approximately about a two-year life expectancy with Lou Gehrig's disease is what he has, and that's this form. It's a little unpredictable, but the true Lou Gehrig's, and there's variants, is somewhere around that time. And GS says, you know what, I love eating, I want to eat again, so I want to see if I can eat. And so when people have a breathing tube in, we always do what's called a swallowing assessment. That's our occupational therapists do that for us, and lo and behold, GS can eat just fine, even though he's got a breathing tube and he's on the ventilator. So he eats. And he stays in ICU for a long time, and he gets to know all the staff, and all the staff love him. And even the people in the coffee shop know him because he can go down and have a coffee. He's a regular in the hospital. And really nice man. And after significant bureaucracy, and it's very difficult to get people home on a breathing machine here because of all the legalities and everything like that, we're finally able to get him home on a ventilator after about a year in hospital. And he goes home. And actually run into him out at my favorite store, Princess Auto. He goes out on day trips and stuff with his family and stuff like that. So unfortunately, the disease does progress, and after about a little over a year and a half, he comes back, and he's now in septic shock with an aspiration pneumonia. He's aspirated food and requires readmission to our ICU. He does stabilize, but he's markedly weak compared to what he was when we had seen him a year and a half ago. And he also realizes, he's a very kind man, he also realizes that over the last few months, he's been a significant burden to us. And he can still speak to us, even though he's on a ventilator. You sometimes are able, not always, and I'll make sure you're clear on that, not always, but we can put devices in when people have a trach that they can sometimes talk around those sort of things. So he's able to communicate and stuff like that. And he really doesn't want to be discharged home because he feels that it's significant stress on his family now. And he also tells us very clearly that his sort of line in the sand, burden is, when I'm not able to eat myself, I don't want to continue on, okay? I don't want any feeding tubes or anything like that put in me. That's when I've accepted that that's a significant burden that I'm not willing to cross. So he stays with us for another 3 months, and unfortunately his swallowing gets worse, and he's no longer, we make the decision clinically that he's no longer able to eat himself, and he's not able to get enough to sustain himself nutritionally. He's enjoying the food he eats, but he just can't eat enough to get into him, and he will not accept the feeding tube. And that's his choice, that's his autonomy. We can't go beyond that, okay? He then says, Dr. Brownbridge, in 2 weeks, I want the opportunity now to call in all my family and friends and say goodbye to them. And what I would like to do is 2 weeks Friday, I want you to get me ready for bed, start sedation, and he uses the word, I don't want to know what's going on, and then I want to be taken off the ventilator with my family at my side. And of course, whenever you have this, it creates significant, is it okay to do that? Is it not okay? Who can we ask? Is he of sound mind to make these decisions? So you cause a whole flurry between social work and psychologists and ethics and they all come in and say, he's of sound mind. He has that right to make that decision. So my question to you is that okay with us as Catholics? And this is where I open it up now. And Bishop can certainly help me answer some of these questions. And I would like you to stand up. We have a microphone here. I want you to sort of give me your opinions on whether you think we can pass the microphone if you don't want to stand up, whether you think this is acceptable as a Catholic. Do we have to continue? Do we have to find wisdom? There's lots of questions this case sort of brings to the forefront.
I have one question about I just have a question about the definition of deep sedation. Like, is that like where he's requesting that he be put on extra amount of sedation? And then that was the one area that I would question in here to try to understand is that he's being given more drugs than normal to keep him to actually that could cause his death. So that was the one. It was just more of a question for clarification.
So that is a very good question. Okay, what does that mean? I can tell you that. And none of us have died and come back from it, okay? But we certainly have people that have nearly drowned, okay? And that sensation of choking and being short of breath and stuff like that is not a sensation for people. So the answer is, what does that mean, okay? So the goal of our sedation, in this case, would be to relieve his anxiety and make sure he's not suffering, okay, if we were going to implement it. Now, what depth that is, that's often left at the discretion of the nurses taking care of them, okay? The problem is, sometimes if patients get into an anxiety, a significant state of anxiety, it's hard to get back on top of that, okay? All right? So we do, as physicians, healthcare workers, and Teresa uses her discretion when she's dealing with these situations, and she has dealt with similar ones. She has to use her discretion. What is the adequate amount of sedation, okay? So it's not just going to be a little pain medicine or something like that. It's going to be more than that, okay, is what it will be. Is that right or wrong?
So palliative sedation is not euthanasia. You're treating the pain, you're treating the anxiety. As a nurse, with him being ventilator dependent for that long, as soon as you would turn off that ventilator, he's going to have trouble breathing really fast. So you need to treat that anxiety. I wouldn't want to feel like I was drowning.
So the problem is we run into is many Catholics do feel that okay, what we are doing is not right, okay? And that leaves us sometimes in a bind, okay? Personally, I feel I am with that patient in the right way and that I am okay, I can sleep at night, and I'm willing to face my maker, but not everyone feels that, okay? And that's an individual sort of decision we all have to make. And I certainly would ask, the bishop's opinion on what he feels,
I think a lot of people may not have had a lot of experience with this, for starters. The caregivers in the ICU, the doctors, etc., have dealt many times with these cases. And so what I would like to address is, what are some of the issues that you, as a family member, as a spouse to this person, or a friend, or family member, niece, nephew, uncle, whatever, what do you need to know? How do you need to inform yourself about feeding or not feeding, or about treating pain? What's the level that we can get? And when does it become so close to the fact that actually that deep sedation is really going to really significantly shorten that person's life? So what's going to happen is, I like to use a lot of examples, and that helps me sort of understand the point that we're talking about. So if I said, this person is dying, I shouldn't wash their brow with a nice cool face cloth. I'm not going to do that. They want to die. Well, you want to give them comfort. You want to give them comfort. So that's a very, very on the far end, a small, tiny gesture of giving comfort. And we always, I would remind you, we're always, as caregivers, doing this in the name of Christ. Okay? How do we continue the healing and the sanctity of life in the name of Jesus, the name of our church? And that's the advice I would give to a Catholic. Okay? How am I Christ for this person? So on the far end, the smallest intervention, giving them a glass of water, dabbing their lips, making the breathing a little bit, whatever, easier. This is a serious intervention of taking away the pain of drowning, as was mentioned. And so now we have a really serious case of attending to the, and a very mild case. And then where does the exact situation that I'm facing today fit in that continuum? Okay? I can't give you that answer today. I wasn't there. And that's why today I'm offering you the Catholic Health Ethics Guide as a guide, as something that suggests to you, here are a few principles, here are some of the values that the church holds. You should know those in advance as best as possible. I encourage you, I strongly encourage you, get a hold of that Catholic Health Ethics Guide to inform yourself about what kind of intervention is possible and not. And so that you have, when it comes to that moment, and you've got to talk to the doctor or the nurse who's going to make a decision with you about what kind of care to give, that you're not starting from scratch, that you've never encountered this before. You have nothing to compare it with. And so to the extent that we as a church can generate some discussion about these values based on this guide that we have, that's what I would encourage, so that you're not coming in cold, as it were, or unprepared as much as possible, so that when you do make a decision, as they have to all the time, they make an informed decision. And that's what I'm encouraging here, that you make an informed decision and that you do what you can in advance of some of these eventualities, either in your life or someone else's, or filling out an advanced care directive, that you know some of these principles. It's about caring, it's about being Christ for that person, but we can do way better than just a cool face. And how far do we go? That's a decision you have to make, but there's a guide there to help you think about that in advance. Talk with your medical team and the caregivers in advance, so that when it comes to that point, you know, he was a year at home. What a perfect opportunity to discuss, doctor, how's this going to turn out? What's going to happen? You've seen them die of this disease 50, 100 times. Facing. That's when you can have that intelligent discussion about what does a Catholic Church teach? How can I really be Christ for my friend, for my husband, for my wife, whoever the person is the sick person is going through this. And that's what I'm here today is really encourage you to talk to your clergy, talk to your ethicist, talk to your doctor, nurse, talk to your family, talk to the people and become educated and knowledgeable about what are some of the principles that the Catholic Health Ethics Guide says, that is approved by the Bishops of Canada, that has its imprimatur, it's in its 3rd edition. How can that help me today be more educated, more informed, so that when I finally make that decision, based on the best care and the best experience that I can gather, when I make that decision, I'm at peace to know that I might be wrong, I might be right, but at least in my heart, I have a clear conscience that I've done my due diligence. I've done the best that I can to get the best informed decision, and then make that decision and give it to the hands of God.
And to re-echo that, it's very important that, advanced care directives may be useful, but they're only as useful as having discussion with yours, okay? When you do them, don't sit in a dark room and do it yourself. You need to do it with your children, and you need to sit down and give them the spirit of the burdens that you're willing to accept, okay? Because then we can actually advise you and your loved ones as a family whether we can deliver that type of care, okay, or not, okay, and get you through this and end up with potentially those burdens or less that you're willing to accept, okay? If it's just a paper that you bring to us, they really are not good enough for us what your wishes are, okay, all right? So I certainly, when my mom was in her 80s, I sat down with her and we had a talk about what she would accept and what she wouldn't. I knew exactly what she would go for, what her burdens that she would accept, what she wouldn't accept, and that type of thing. And that's what we need as healthcare providers is, what do you want? What are the burdens that you will not accept in your going forward? And we don't speak as Catholics about quality of life, because quality of life is too many different yardsticks measuring quality of life, okay? You can argue the same about burdens. You can say they're very subjective. But we as Catholics speak about burdens of existence, and those can be financial, they can be social, spiritual, they can be many different things, but that's how we sort of outline what would be acceptable to us. And the other point about this is, even though he was requesting that his life be, potentially taken off the ventilator, yes, Lou Gehrig's disease, ALS, is a terminal disease, but with technology, he might have got another year, okay, with another feeding tube or whatever. Is that okay after 2 years? Do we have to honor his opinion? These are all questions that sort of come to the forefront. And people, even if it's not a terminal illness, we as Catholics don't believe that you don't have the right to say, I've had enough, this burden is too much for me, okay, all right? It doesn't mean I end your life, but it also means that you have a right to say, no, I refuse that aggressive care, I don't need that, okay? So that's the difference, okay? It's not an active sort of thing, it's a decision you've made. I, as a physician, should not convince you to go that route, that's a decision you have to come to, but it is an acceptable alternative.
Sorry.
Go ahead.
I just want to stress it's important to remember your definitions. Euthanasia versus, for example, palliation, right? Euthanasia is always with intent to kill. It's not comfort, it's not pain relief, it's just to kill. And there's a big difference.
Was there any other questions on this case? We have another case that we want to look at, but perhaps there's another question about this case.
So, bring the microphone.
I was just going to say that a few years ago I was told by Father Mark Miller, who was at St. Paul's Hospital.
He was a very good ethicist.
Yes.
Yes.
That, and I was a social worker, and I was facing this with a client, and I was told that as long as a Catholic, we did not have to agree to extraordinary measures, and I've always had that in our mind. So I think for us to learn what these extraordinary measures are is helpful. It's like a feeding tube, things like that.
Sure. So the problem with, those come into ordinary and extraordinary measures, and then they're also called proportionate and disproportionate is what we now, they become very confusing. I'll tell you why they become very confusing is, me doing everything for a 12-year-old, potentially I can restore that child to a full life and everything like that, okay? So extraordinary measures in that child are not that significant, okay? Let's say you have a threatening illness that with multiple disease processes, and I try and do everything for you, your outcomes are not going to be as good. You just don't have the reserves, okay? So that's why everything we do has to be put in proportion, whether they're ordinary or extraordinary, to what we're dealing with as the patient. It's not black and white, it's many shades of gray, and that's the thing. And you're absolutely right. Father Miller was an amazing, he helped me sort of work through many of these sort of things, and he sort of opened my eyes as well that, no, we don't have to do everything. This is acceptable. We can let God, go meet God. If that is your wish, it's not wrong to take that approach. And I think I actually miss him being on our ethics at St. Paul's, to be honest.
So looking at the continuum again, what's an example of intervention? I might have a headache and I refuse to take an aspirin. I'm just going to let it course. I refused medical intervention in the slightest of ways. I may take more aggressive okay? And so defining exactly what is aggressive, what is not, or what's extraordinary. Because today, what is normal or not extraordinary 25 years ago was extraordinary because of our advances in technology. So that's a moving target to say extraordinary, what's not extraordinary. Let's look at the example of Christ. Christ is on the cross, he's given gall. He refuses to taste it. He refuses to drink it. They were offering him something on that spear, and he refused it. It's okay to refuse. I might have cancer. I may refuse all kinds of treatment. That's my option. If that's my choice, given what kind it is, responsibilities I have, whatever. I may say, no, I'm just going to let it go. I just want to be treated for pain. I'm not going to take anything that's aggressive and going against that. That's my choice. Allowed to do that.
I think a lot of people with extraordinary measures, sometimes you hear people say, oh, they'd want everything done, but I think that's where sitting with the advanced care directives is good, because a lot of people don't know what everything is and what it entails. And once you start down that road, you can always refuse and stop.
Yeah, that's the other thing that's very difficult in medicine now it's becoming, and the courts have just told us this as well, is that in Canada, we have to continue care unless we have the patient or the family's blessing to withdraw that care. That's what our Supreme Courts have told us, based on a very publicized case in Ontario, where a patient was basically in a vegetative. The physicians wanted to withdraw care and let nature take its course, and the family said, no, you can't do that, okay? And so what the court said was, we don't have to do everything if we think it's futile care, okay? We can make that decision, so you can't come in and say, Dr. Brownbridge, my arm pains me, cut it off, okay? I can say, no, I'm not cutting your arm off, okay? That's a crazy sort of thing. But once I start life support, I can't withdraw it unless I have your blessing as a family, okay? Or as the patient, okay? What's clear about it. But I don't, as an intensivist, have to offer life support if I think it's not going to make any difference. And that's a clear difference, okay? And then, so when your loved one comes into emergency and they're very sick, you might run into an intensivist that says, unfortunately, we probably can't make a difference, okay? We suggest that you move on to compassionate care for your loved one, okay? Once I start the life support and admit your loved one to ICU, then I need your blessings and consent to withdraw life support. So that's where, even though I'm going to recommend it or whatever, if things aren't going well, unfortunately, you're still left in the loop to feel that I've made the decision that I have to withdraw it, okay? And so sometimes it's best with our loved ones to make sure we know what they want, so we don't have to walk down that street and then decide that we have to stop it, okay? And that's the tough thing in medicine nowadays. Okay, another case there.
Okay.
So this one is even sort of a little more emotionally sort of charged, in that if we'd like to know how this worked out, GS actually did have his way. He was sedated and had his wife there. He went down to Tim Hortons, had his coffee that day, said goodbye to everybody in the hospital, made his rounds, and then on Friday night, he got ready for bed and had his sedation, and he was taken off the ventilator and passed away peacefully in a short period of time after that, sort of thing. You can argue, is that not okay? I actually think it's okay personally, okay? But you'll have to decide, and you're going to run into Catholics that don't feel that's okay. So from my reading, I feel I can sleep at night because I believe we do have the right to do that. This is another case. It's a little camouflaged, but it's a little more difficult. This is a 25-year-old male who was a very energetic and truthful. His family was also Catholic. He lived life, and unfortunately, he was involved in a bad accident when he was doing snowboarding. He ran into a tree and had a severe head injury that left him in a deep coma. And investigations showed severe injury to his midbrain and his brainstem that basically control your wakefulness and some of your basic functions in life. And so he also caused his brain to shear, had what we call diffuse axonal injury. So if he survived, the prognosis was that he would be left with severe disabilities to the point where he would probably need care the rest of his life. And the neurologist went on to say that the longer he remained in a coma, the worse the prognosis as far as outcomes go. So because of his sort of young age and stuff like that, the care team, the healthcare team, we planned for long-term care and hope that he does get better from this horrible, horrible head injury. And the family were reluctant. The family were not. They were a sophisticated family. They were faithful as well, and they had a daughter who was a healthcare worker and had experience. And they were a little reluctant to move along this path, but they agreed to move along. And so their son had a tracheostomy performed and also a feeding tube inserted as well. And a wise Catholic doctor told me, whenever you're being sort of asked whether we should do a feeding tube, here's what he said to me, is he said, a feeding tube should be a means to something, okay? And that means it's to get you better, to get you to a state that sort of allows you to survive. It shouldn't be a means in itself, okay? And that's sort of where it becomes a little antsy. And Catholics struggle with enteral feeds and fluids and everything. But even I think we sort of have to think, what is the purpose of the feeding as well? So in these cases, a feeding tube was inserted. Well, as often happens when you have a tracheostomy and you're not breathing 100% and you're kept laying down, the human body is used to being up. He developed a severe hospital-acquired pneumonia, and it was an overwhelming infection, and he needed to be readmitted back to ICU or he was going to die of this infection. So he needed more support, okay? And this was over 3 weeks from the time he left us in ICU. So now this is going on 4 or 5 weeks into his course. And the family, after considerable deliberation and everything, they came to the conclusion that this is not, escalation of his care is not what he would have wanted. That this burden of his survival would not be what he would want. They went on to tell us that he had a friend that was involved in a motor vehicle accident and was high quad, and DY had said he would never want to survive that type of injury. So he had sort of given sort of history. The family were aware of what was involved, and they did not want to sort of move on and move their young 25-year-old son to ICU. And yes, we probably could have got him through this with support of his blood pressure and his ventilation from a medical point of view, but the family is saying, no, I don't want this. And it a great deal of angst amongst the healthcare team. He's 25, we're not sure the prognosis, he may or may not survive. Those are the questions I have of you as that I hope you never have to face this, but unfortunately you may be facing something similar like this, that you will be the proxy that we go to and say, what burdens are they willing to accept? Questions on this? Have any thoughts on those questions I've sort of brought up there? I don't know where the microphone went, but oh, Deb's got it.
So in case you can't read the print from the back, the first question is, does the family have the Catholic ethical right to refuse care that's life-sustaining? And the second question is, can we refuse care for our loved ones, even if the process they are facing is not terminal?
I'm going to role play something, okay? So I'm going to say, Doc, I know you explained it to me, put it in very simple language. If we give him palliative care, we don't take him to ICU, what do you think will happen? So let's call that option 1. If we to ICU, and he's on a ventilator, and he's kept alive, but there's really no change in his condition, let's call that number 2. Am I clearly understanding what my options are, 1 or 2? Or is there an option that I missed?
No, those are your 2 options, yes.
See, so you can ask for that clarification.
Kind of an issue that I've often thought about. If a person is severely injured or becomes very ill, do they have to go to the hospital? Because it seems to me if we ourselves or if others take us to a place of healing, we should probably defer to professional opinions and experience. And if you're going to argue with them, why are you going there in the first?
I would like to start with something here and certainly cut in with you when you wish. I'm reading from the Catholic Health Ethics Guide, the current edition. It was put out in 2012. I'm just going to quote one little paragraph, okay? And it was alluded to earlier by Dr. Brownbridge, but a Catholic perspective respects both body and spirit, the individual good and the common, the person and the community, personal faith, and belonging to an organized church, and that can speak with authority and encouragement. Okay? So what I would want to bring to the fore in your question is, I'm sick, I choose not to go to the hospital, I might have my reasons, it's going to be expensive, I don't want to go there, I've got a fear of hospitals, whatever, I might have that decision. Okay? I think that there is a responsibility and a duty that I have to talk to my family, because I am a family member. No person is an island. We are a community together. And what I choose and do is going to affect my caregivers, my family relationships, my friends, and even those I don't get along with. And so some conversation, I think, is beholding there. So, you know, just to act on the fact that this is not just me alone. Okay? Yes, there is that limited autonomy that I can choose what I want to accept or not accept, etc. But there is also that duty to life. And if it's a simple cut, and if I don't attend to this, it's going to fester, it's going to get worse, and it's going to eventually possibly involve many, many other people. How selfish of me to decide I'm not going to do anything about it. I'll give you a case. A person who cut his finger open on a hydraulic leak on a hose. He was looking for the and didn't realize, wasn't thinking, here's this little leak because it's spraying around, and he ran his finger along the hose. This is coming out at 5,000 pounds per square inch. And he didn't even feel it, but it just sliced his finger open. This little thing of oil. He went home, he rinsed it off, wrapped it up, kept on working. I'm not going to go. Well, his infection becomes a systemic. And now the doctor is proposing, cut your arm off right over here, because this is all infected. And he says, no, I'm not going to do that. And you know, it's not just your personal decision. You have the ultimate maybe say in the end, but what an uninformed way to make a decision. And what a selfish in some way, arguably, what a selfish way to decide. There are other people. We are a community. We are a church. And I think those things should at least be considered before a decision is made.
I think the answer to your question is yes, you have that right, okay? But I totally agree with Bishop in that our experience is you did not communicate your reasons and your wishes to your family. And you get sick and you get unconscious and you're left along and they find you that way. And then they bring you to us, okay? All right? And we get involved and we're going to keep going until we know what your wishes are or want, okay? So the answer is yes, there's many reasons why it's totally reasonable to stay at home and be nursed and taken care of and at home, sort of thing. But I agree with Bishop. It should be something that probably is not going to get better, you know, a minor condition that's not going to get better. Most people don't take that approach. They're fairly reasonable, but many malignancies, it's not like, okay, you're going to, you know, when you have a cancer, you come into your doctor, and when we say you have 12 months, well, 12 months is actually a curve. You could have 3 years and you could have a month, okay, is what the reality is. You don't know if you're going to get 3 years. The average is 12 months, okay, is what it is. So if you have a life-threatening condition and you make that decision, let your family know that that's what you want. Some jurisdictions in the world, in Australia and New Zealand, if you don't want to be resuscitated and aggressive, you actually put a sticker on your fridge. So when EMS comes into your house, that's the first place they look, and then they know what to do when they come in your house if you're living alone, okay? Those are some of the things that we need to start thinking about as a society, about, you know, where we put the information that people have.
Hi there. In this case with the young 25-year-old man, I have mixed feelings about this because what is it saying about people with intellectual disabilities? Like if he were to live the rest of his life with an intellectual and physical disability, do we have a right to say to God, I don't want to live that way, so just kill me, you know, if ever that happens to me?
Yeah, and that is the true difficulty we deal with these situations is that absolutely people with disabilities bring joy to our lives all the time, and they're an important part of our society. They humble us. There's many things they do to us as far as bringing benefits to our society. The question comes is, patients have a right to decide what sort of burdens they're willing to accept. And I, as a physician, have to respect those sort of decisions. I can bring in ethicists, and I can tell you that there was ethicists involved in this case and everything like that. But once the family comes and makes this decision, do we have to accept it? And if I don't, how do I move around it and sort of get around these issues? Because they're issues we deal with, Teresa and I, not infrequently.
Yeah, I do. It kind of touches on one topic that I want to raise here, and that is about meaningfulness in suffering. Okay? So if I have some setback, or even more stronger than that, a disability, okay? I'm already beginning to be dependent on others to help me, or asking the church to put in a ramp so that I can still come to church, and it involves many other people, right? What is meaningfulness in suffering for one person may be a stupid burden for somebody else, okay? And so perspective on what is involved there is very important. I like to take, again, starting with Christ, he takes the most inhumane and useless humility to suffer, dying on a cross at that time and era of society. And he turns it on its head. He makes it the most meaningful thing to show his love to us, and gives it to us as a gift, and completely transforms what crucifixion is about. I like to look at society and I ask myself, how is it that somebody may not find meaningfulness in their suffering, or it's just degrading, or I have to beg people now to help feed me or change my diaper or whatever it is, and that's no dignity at all, and I may want to end my life. That is definitely some suffering. And yet again, on the other end of the perspective or the continuum, here, and Saskatoon happens to have the record still running, we have the largest gathering of people in Canada indoors to recognize those who suffered and died for us on November the 11th. And we sustain the meaningfulness of their suffering, their being maimed, and their eventual death, or the tearing up of their family life, or the stress, or the anguish, or the spiritual, or psychological, or whatever kind of suffering and pain they endured. We want to be reminding them and ourselves and their family and their children and their ancestors and those family that follow. It was meaningful. It was meaningful. So I put to us for our reflection, when you find meaninglessness in suffering and pain, I ask, can we find some kind of meaningfulness in that? Even for me, and I'm not going to impose that on anyone. To me, the ultimate meaning in all of my suffering is if it's for God's will. And I don't know exactly what that is. But if I can be of the mindset that whatever I am suffering, even though it seems completely useless, 100%, nobody can tell me that it's good or going to help or it's going to be powerful. If I know that it's going to be for God's will in my heart and mind, may I have the strength to accept it. May I have that. That for me is putting meaningfulness into any, suffering that I might have to, okay? And so there is that possibility, I'm going to say it that way, there is the possibility of redeeming even what might be the most meaningless suffering in any case. For me, there's always that possibility of redeeming that in a powerful way. And I don't know all the details. I don't know how it's going to bring forth from someone else their capacity for compassion. I don't know, call forth the goodness in another human being. It might. God may want to use me for that. And so that's what I would have to probably comment on your question is, whatever condition that person would be in, even if they did take him to the ICU, we're not saying it's meaningless. It's very, very powerfully meaningful. And yet at the same time, also remind myself, Jesus gave me a free will. Who am I to take that away from you? Jesus doesn't take my free will away. That is one of the, I like to put it again in my terms, that's one of the images, that's a part of the image of God in me. That I have a free will and that I have to inform and make the best informed, conscious decision that I can. And I think, for me at least, that's part of doing God's will.
And I just wanted to touch on the angle you mentioned, the vulnerability. I know with this case, with the diagnosis that he had, he would probably be looking at a long-term care, a nursing home, a feeding tube, possibly lifelong ventilator support. So for 25, looking at a long life with what kind of quality and burden, right? Like sometimes patients will ask me, well, if it was your child, what would you do? And in this case, I would let them go as well.
You may choose, we're going to go that route, but maybe for 3 years, or for 2 years, or we don't know. It could be as long as 25, it may be as short as 1. We don't know. We in history, but
I guess this is the thing that's very complex now. So DY, we could potentially keep him going for 25 years in a vegetative state, okay, all right? And as I said, we don't talk about quality, but we certainly consider the burden to his dignity, to the family's, lifestyles, having someone with severe disabilities carries disability to caregivers. 30-some% of ICU nurses are burnt out in the world now, and that's modern stats because of futile care. They feel they're delivering futile care. That is the reality of it, okay? So we do have to realize that when we ask people like Teresa to give care to someone that she feels is futile, it has a significant psychological effect on Teresa as well, okay? That's the complexity of the things we're dealing with. Very difficult. There's suffering amongst all of us. There's burdens that the whole sort of care team and families deal with. And I totally understand what you're saying is that you have someone born with cerebral palsy and that sort of, those children certainly need to be cared for and kept alive and stuff like that. But the struggle I have is, does the family have a right to ask this? Because some people would say, you're actually euthanizing this child because you're refusing care. This isn't a term. He's going to go on living for a long time with care. But because I've refused care, that's the same as giving euthanasia. Because the family were told, if we don't go this route, it's likely your son will die, okay? And they still elected that is the route that they wanted to take, okay? Yeah, questions? Where's the microphone?
So just to reiterate, there are so many fine nuances. Again, the Catholic's Guide is there to help you be informed. Inform yourself about the values, inform yourself about the technology a little bit, but mostly about the values, and then puts you in a better place, hopefully, to ask specific questions of the care team. And then in the end, for you or whoever lies with to make that decision about what to do in an informed way as best. There's no guarantee in right or wrong answers here.
This is my last comment on this situation, but if this was me, I'm wondering if my parents made that decision, if they'd be robbing me of suffering to the fullest with Christ and becoming as holy as I possibly can as a living human being.
And that is certainly something we see, okay? I'll give you an analogy, and these are the ones that I actually have been called into. A young 42-year-old woman has metastatic cancer, okay? And she develops respiratory failure. The cancer is actually coming through her chest and stuff like that. It's a horrible case. And the family wants us to continue because Christ is going to have a miracle on their wife, okay? All right? All right? But everything we do to her is painful. We turn her bones break. We're like, I hear what you're saying, okay? But there's a cost to that sort of stand as well. And it's not, I don't want to interfere with your feelings of being close to Christ and everything like that. But there's a whole bunch of us in this care plan, okay? All right? And it affects many of us as well, not just your wishes as well. And that may be your autonomy to make that decision, but it's also, we're all after of believers and people as well. So that's why I'm not going to give you the answer. But what I always do is I always say, I don't go to my lawyer and accountant and say, you know, I ask them, what do you think I should do, okay? And I encourage you to do that to the physicians. And when they give you advice, take that advice very seriously. And when you go against that advice, do so at your own peril, because they're bringing a lot of experience to that advice, and we don't make that advice sort of, you know, this was your mom, this was your child, what would you do? And as I said, I think that brings some great deal of experience to it. And if you sort of say, no, I'm not going to do that, then realize that, you know, potentially that's maybe not the best decision. We're not always right. I'm not going to say we're always right. But in these cases, we take our recommendations very seriously. And the nurses that do the care as well, so.
I'd like to just bring up an analogy I use sometimes. When you talk about the technology that's keeping the person alive, okay? Take away the technology. If you take away all that technology from the person, think back to when you were little and you watched Waltons or a show like that. What would have happened then? They would have had their family's arms around them. They would have been in bed. They would have gotten stories read, children laughing. There's such a glory to God to have a good death with your loved ones around you without the technology. The technology doesn't bring you closer to Christ. Having your family there and having Christ shine through you and your loved ones at that time, that's Christ in the midst.
We just have one more question back here, and then I'll transfer the mic up front.
I just have two comments, or one comment and one question. I'm just interested in your reaction to the argument that if somebody is ill, disabled, is that not a challenge for the family? Is God not challenging them to care for this person?
And the answer is, it's the degree of that challenge, okay, as well. And I'm not saying, and you can argue that God never gives you anything that you can't handle, okay, all right? There may be some truth to that, but those burdens can be pretty severe and pretty devastating to a family as well, okay? So the answer, let's be honest, most of our highly disabled children are not at home, okay? They're in institutional care because most families can't deal with the burden of that, okay? It's not to say there still isn't a burden and they don't visit them, but the reality is it's caregivers that are often giving the day-to-day care in those situations, okay? So I hear what you're saying, okay? And there's no question, many of you may be dealing with patients, our audience here tends to be a little more gray hair. Many are dealing with patients with Alzheimer's. Their loved ones have Alzheimer's, okay? That is a huge burden on caregivers. That can be so devastating to a point where it affects the healthy one's health as well. So the answer is yes, we have to do our best, and disability brings us sort of rewards as well. And I'm not saying we do it with all disability. That's not what I'm saying. What I'm saying is we have to realize that people have a say, this disability This burden is too much for me, but that doesn't mean we have the right to end that person, okay? When decisions come along that are sort of a passive way of allowing that person to pass away, is that okay in our belief? And the answer is every one of us will have different views about that. And I always talk about forks in the road. There's going to be a decision where you can continue this care, or you make a decision where usually it's an infection or a patient or whatever. Do you have to treat that when that happens in these situations? And the answer, in my opinion, is no, you don't.
I was handed the mic, so I guess I can ask the question. I'm hearing all you're saying about stopping treatment and passively letting that beautiful good death that Teresa's talking about happen. What about in June, when the legislation changes and that is a much more active advice that we make from a doctor to end a life actively and deliberately? Have you thought about that, and what are the implications you ever thinking about?
Okay, no matter what we do, there's going to be a small percentage of society that's going to request this, okay? Almost based on that's my right to ask it, okay? The reality is, as the Saskatchewan bishops, the answer comes in improving palliative care. That is the true answer to reducing the need for this, okay? It's very similar to life movement, supporting young women through this and stuff like that. We have to be proactive, and we have to push our governments to put more funding into palliative care. We have wholly inadequate palliative care across Canada now. And that is the answer. That is why people ask, is they feel they've reached their suffering point and they don't want to suffer anymore. Whereas if we can get good symptom management, and that's what palliative care means, is symptom management, okay? That's what the word means, is if we can help most of them, but we don't have the resources right now. And the Saskatchewan bishops said exactly the same thing. Questions?
Perhaps this will be our last question.
Actually, it's not a question. It's just, I want to commend the organizers as well as the three of you for coming on this topic. For me, personally, it came about 2 months too late, because in November, my mother passed away from dementia. She basically starved, and we had to make a decision without a healthcare directive in place as to what we were going to do. And we were told, and she was in a personal care home, and she just stopped eating, and as a result of that, she just taught, I think, how to eat. Or, I mean, there's lots of questions around why people with dementia, Alzheimer's stop eating, but anyway, she did. 89 years old, no healthcare directive in place, and we had never had the opportunity to ever talk to her while she still had her faculties as to what we should do. So we certainly wrestled with that. We did contact Father Michael to talk about that. We prayed about it as a family, and then came to the conclusion, because we could have had her to a hospital, and they could have force-fed her to keep her alive, but it got back, and what you said was absolutely right, to what end? And basically, we decided that no, we weren't going to do that. We weren't going to intervene and just let nature take its course, and ultimately, she did pass away a couple of weeks after she stopped eating. But this is an absolutely really good topic to inform people, particularly Catholics, and really appreciate those that organized it on today. So she should be commended for that.
Thank you.
I'd like to ask Deb to come up here with the microphone. I think, again, the Catholic Health Ethics Guide is one of many ways that, again, we can evangelize others. We can evangelize ourselves, we can evangelize others, concrete way. This is not talking about Trinity, perhaps in a theological sense, or icons or anything. This is talking about our Catholic identity, the values that we hold in the gospel in a very tangible way that everybody has to face in some measure, if it's a taxpayer or the primary caregiver. And this is a wonderful venue and way to evangelize others by becoming familiar with this book and sharing it with others as much as possible. That this is our way of trying to be Christ in the world today, particularly in this focus with caregiving. So I really want to really encourage, there's just 2 days ago, clergy meeting and conference, and we had a nice presentation on behalf of the Catholic Health Association of Saskatchewan, CHAS, and we ordered 100 books. So we're going to have 100 in our office. You can also order them through other means. But I'm going to give the last word to Deb.
There's just one more question.
Oh,
And this is such a good discussion. I know you said it was the last one.
I will commend that book. That's a very useful book. But Google, if you do, The Catholic Tradition of Dying, I think it's called. If Teresa and Bishop both have it, you can Google it. It'll come up. It's a very good article that goes through euthanasia, tube feedings, all of this stuff, what our tradition is as Catholics. And I think part of the problem is we don't understand our traditions too. So go ahead there.
I just have one question. You brought all these different aspects of being ill, and the decision was taken done by the medical team as well as the family. Now, in my case, I'm asking, what happens when I make a living will? Are you going to is it still going to be a dialogue between the family and the doctors, or is my will going to have a definite vision of what I want done?
Okay, so what I would suggest you do in the living wills, they sometimes can give us some information, but many times, ma'am, it'll say, if my care, if the hopes for me is futile, then I don't want anything done and make, okay. The problem is, what is futile, okay? All right, that's a call, okay? And most times we may be able to get you through that, but of your existence may not be something that you're willing to accept, okay? So what you need to do is still do your living will, but sit down and explain or have your loved ones know exactly what you mean by, Mom, are you willing to accept tube feed? Are you willing to accept the breathing machine? How long should we continue that for? Those are the kind of questions that we're going to be asking as healthcare providers, because we need some directive, okay? Because honestly, most living wills don't help me as an intensive physician, because they're too vague, okay? And we can do a lot of harm and not necessarily make a difference. Because under some circumstances, you get a little bit of pneumonia. I can put you on a breathing machine and get you better within 3 days, okay? But if I put you on a breathing machine and it's 2-3 weeks, that totally changes your outcomes, okay? What's going to happen, okay? So it all depends. It depends on the duration, what your sort of health status is before you go into it. So it's all kind of a gray, different colors of gray, whether I should do that or not, okay? What I need to know is what you're willing to accept in the end of your care. That's what we as healthcare need to know.
Thank you, Doctor, and thank you, panel, for this excellent, excellent discussion. And we do really thank you for all your questions. I appreciate that we have gotten to everybody, but this is such an important topic, and we really appreciate your coming out today. Thank you, Dr. Brownbridge, Bishop Brian, Teresa. Thank you.